welcome to the deep dive. Today, we're untangling a really tricky idea, medical competence. What truly makes a doctor competent? It's fundamental to medical training, obviously, and something, well, we all think about when we see a doctor. It feels like it should be simple, but it's really not.
Exactly. Yeah, you'd think there'd be a straightforward checklist, right?
Right.
But the actual work a doctor does, it's so much richer, more varied than that.
Right.
And that creates this real tension. You've got the need for standardized medical education on one hand, and then the reality that healthcare is delivered by unique people in all sorts of different settings.
And that's precisely what we're diving into today. We've looked at some fascinating research that suggests a new way to think about medical competence, not as just one thing, but as like three interconnected layers. So our mission really is to unpack this framework and see how it might help bridge that gap you mentioned between the standard stuff and the individual side of medicine.
Yeah, and this framework suggests thinking about competence in three parts. So first, there's what they call canonical competence.
Okay.
That's like the absolute bedrock, the knowledge and skills every single physician needs no matter where they work. Think, core science.
Got it.
Second is contextual competence. This is where that core knowledge actually gets applied, where skills get used, attitudes adapted, all within a specific place, a hospital, a clinic.
Makes sense, because, big city trauma center is totally different from a small rural practice.
Exactly. And then the third layer is personalized competence. This is the really individual bit. The unique way a doctor blends their own personal skills, maybe their interests, their habits, even their core beliefs into how they practice. It's what people often mean when they talk about the art of medicine.
Okay, interesting. 3 layers. Let's peel those back then, starting with that first one. Canonical competence. What are we really talking about there? What's in that layer?
So canonical competence, at its heart, it's the non-negotiables, the sort of fundamental truths and principles of medicine. It's that deep understanding of, how the body works, what goes wrong in disease, the evidence-based ways to diagnose and treat things. That's the foundation.
Right.
It's the essential stuff that ideally every doctor should master wherever they end up practicing.
So like the basic sciences, physiology, pathology, pharmacology, the things you learn right at the start of medical school. That baseline knowledge.
Precisely. Yeah. The research points out that even though medical knowledge is, huge and always growing, this canonical layer covers the really critical bits for understanding health and illness. It's the platform everything else is built on.
Okay.
But what's interesting is it's not just scientific facts. It also includes core professional norms and values, like, ethical principles from professional codes. And even a basic grasp of social factors affecting health. Stuff every physician should know, regardless of context. It's the essential toolkit, basically.
That makes sense. The absolute bedrock, the must-haves, like you said. Okay, so how is this layer developed? And maybe more importantly, how do you assess it?
Well, because it's meant to be context independent, assessing canonical competence tends to use standardized methods. The traditional stuff.
Like written exams.
Exactly. Written exams, online tests, maybe simulated skills labs. The goal is objectivity, to make sure everyone's got that foundational knowledge, no matter who's assessing them or where it happens. These often check if someone knows how and can show how in a controlled setting. And generally, if you don't meet these standards, you don't move forward in training or get your initial license. It's about confirming that fundamental understanding is really there.
Okay, so layer 1 sets that essential foundation. Now let's move up to layer 2. Contextual competence.
Yeah.
This sounds like where that textbook knowledge hits the messy reality of actual healthcare.
You've absolutely nailed it. Contextual competence is, where the rubber meets the road. Taking that, let's say, clean canonical knowledge and making it work in the real messy world of a specific healthcare place.
Because the canonical stuff isn't enough on its own.
Right. It's not enough to actually practice. Medicine happens in a context at a particular hospital, a clinic, with its own team, its own ways of doing things, its own patient population, even local habits. Contextual competence is being able to adapt your knowledge, your skills, even your attitudes to fit that specific environment. It's knowing how, and crucially, being willing to apply that core knowledge effectively within those real-world limits and opportunities.
Do you give me a sort of concrete example? How might that adaptation look?
Sure. Okay. Imagine a doctor, right? They have a really solid theoretical grasp of managing heart failure. That's their layer 1 canonical competence.
Got it.
But then they start working in, say, a rural community health center, limited access to fancy diagnostic tools, maybe a patient group with unique social challenges.
Yep.
That's where contextual competence kicks in. They need to adjust how they diagnose, their treatment plans, how they talk to patients, all to fit that setting.
Right.
They need to figure out the local referral system, work well with the community health workers already there, build trust with those specific patients. It's about tailoring the best practice to what's actually doable and appropriate locally.
So it's not just knowing the ideal textbook treatment, but knowing the most feasible treatment, the right treatment for those circumstances.
Exactly that. And this layer involves a lot of behavioral stuff, attitudes too. It's not just having the knowledge and skills. It's also showing things like, integrity, being reliable, humility, taking initiative within that context. Being trusted to actually do the job relies on competence at both layer 1 and layer 2, supported by these professional behaviors.
So how on earth do you assess something so tied to one specific place? You can't just give a multiple choice test on how well do you adapt to clinic Y, right?
Exactly, you can't. Standardized tests just don't cut it here. Assessing contextual competence, it really relies heavily on workplace-based assessment. Meaning observing people doing the job in various real clinical settings. Watching patient interactions, having deep case discussions with supervisors, objectively evaluating technical skills as they're being used, even getting feedback from lots of people, colleagues, nurses, other team members.
Yeah.
The focus shifts. It's less about looking back at what knowledge they've banked and more about judging forward. Can we trust this trainee or this doctor with more responsibility within this specific team and environment?
So it's much more about expert clinical judgment, maybe from a group of people, rather than just a score.
Absolutely. It's about building up a gestalt, the overall picture of their readiness pieced together from all these different observations, seeing if they can practice effectively there. Clinical competency committees, for instance, they bring together multiple expert views to decide on a trainee's progress, their readiness for more independence. The aim isn't really to rank people against each other, but to figure out if they've hit the level needed to act safely and effectively in that specific context.
That makes perfect sense. You need to see someone actually doing it, dealing with the unique stuff of their workplace.
Yeah.
Okay, let's move to layer 3 then, personalized competence. This sounds like where the individual doctor really comes through.
It is. Personalized competence basically acknowledges that even when you have doctors who meet all the required standards for layer 1 and layer 2, there are still going to be big individual differences in how they actually do medicine. This layer includes their unique personal skills, maybe specific things they're really interested in, their individual work habits, their deeply held beliefs, all mixed in with their personality.
Okay.
It's that distinctive way a particular physician practices, often what we call the art of medicine.
So it's about their individual style, the unique way a more experienced doctor or maybe a specialist approaches things.
Exactly. Think about, say, surgeons. They all stick to core surgical principles, right? That's layer 1. And they adapt to the specific rules and team in their operating room, layer 2.
Right.
But experienced surgeons often develop their own preferred techniques, subtle ways they do things. Trainees learn a lot just watching these variations, figuring out what's essential versus what's just Dr. Smith's preference.
Yeah.
And over time, often after training is done, surgeons develop their own distinct surgical style. That's personalized competence right there.
The research mentions some really interesting concepts here, like Vygotsky's Perzivani. Can you unpack that a bit? Sounds complex.
Yeah, Perzivani. It's a rich Russian idea, hard to translate perfectly, but essentially it means lived experience.
Lived experience. Okay.
It's the unique way you personally experience and sort of internalize things that happen, shaped by your emotions, your past learning, your personal history. Vygotsky thought this deep subjective experience really influences our creativity and how we interact with the world.
So how does that apply to medicine?
Well, in medicine, a doctor's past experiences, maybe a really tough case they handled or a significant mistake they were involved in, those things can shape their clinical judgment and practice in very personal, unique ways. It's how their own professional journey informs their unique art of patient care, if you like.
That's fascinating. So it's not just what you know objectively and what you can do demonstrably, but how your own journey, your reflections on it, shape how you actually practice. The research also brings up cognitive load theory and self-determination theory here.
All right.
How do they fit in?
Right. So cognitive load theory suggests that as doctors get more experienced, core tasks become more automatic. They don't have to consciously think through every single step.
Frees up brain space.
Exactly. It frees up cognitive resources. And that allows them to take a more personalized, nuanced approach, bringing their individual insights in because they're not bogged down by the basics.
Okay. And self-determination theory.
That theory highlights how important it is to feel competent, to feel like you have some autonomy in your work, and to feel connected to your professional community. Those things drive intrinsic motivation.
Right.
So once a doctor has a solid handle on layers 1 and 2, they're more likely to push themselves further in areas they're particularly interested in or good at, driven by that internal desire to be excellent. It connects with that idea of trying to reach your full potential.
So while layers 1 and 2 might be more about meeting external standards, ensuring safety and quality, layer 3 sounds much more about the individual doctor striving for their own personal best, building on their unique strengths.
Precisely. The motivation kind of shifts. It moves from fixing weaknesses to get up to standard, towards refining and expanding areas where they already excel. It's about setting and beating your own professional standards, going beyond the baseline needed for a license.
This all makes total sense conceptually, but how on earth could you possibly assess something so personal, so individual? It sounds like trying to grade art. Impossible to standardize.
You've hit the nail right on the head. The research argues really strongly that personalized competence cannot, and frankly should not, be assessed for things like getting a license or any formal external checkup.
Really? Why not?
Because external standards for quality and safety, they rightly focus on layers 1 and 2, making sure everyone has the foundation and can apply it safely in context.
Great.
Trying to standardize or formally grade this individual art of medicine, well, first, it would be incredibly hard, but second, it could actually crush the very personal growth, the creativity, the innovation that this layer represents.
So it's much more about recognizing it, valuing this individual excellence when you see it, rather than trying to stick a score on it.
Exactly. Excellence here is usually recognized informally, by colleagues, by peers, and importantly, by patients who feel the difference in the care they receive. It's about appreciating someone's dedication to really optimizing how they work, their unique way of solving problems, their willingness to share what they've learned the hard way with others. You know, like a senior doctor mentoring a junior one saying, look, in my experience with cases like this, doing X often works out best. That's often them sharing their personalized competence.
Right.
So while formal assessment is off the table, encouraging self-reflection, helping doctors set personal goals for growth, that becomes really important at this stage.
This 3-layered model really gives such a helpful way to look at medical competence because it respects both things, the absolute need for standards to keep patients safe, and also the vital role of individual growth and that pursuit of excellence in the profession.
Absolutely. It helps us get past a sort of simplistic checklist idea of what makes a good doctor and embrace the much more complex reality of medical practice. It recognizes we need that solid foundation, the ability to apply it well everywhere for patient safety that's non-negotiable. But it also celebrates and values the different approaches and the continuous striving for excellence that individual doctors bring.
So just to quickly recap then, we have layer 1, canonical competence, the essential, standard knowledge and skills, checked with traditional tests. Layer 2, contextual competence, adapting and applying skills effectively in specific places, assess more through observation and judgment in the workplace. And layer 3, personalized competence, that individual art of medicine, built on the other two, driven by personal motivation and experience. Something to be recognized, encouraged, but not formally judged for licensing.
That's a really clear and accurate summary. And it's worth remembering, I think, that even though we talked about them one by one, in reality, these layers develop kind of in parallel, and they're always interacting throughout a doctor's whole career.
This has been a really, really insightful deep dive into such a core concept. It definitely makes you think again about what competence really means, not just in medicine, which is obviously complex, but maybe in lots of other professional fields too.
Indeed. And it really highlights that true professional maturity isn't just about ticking boxes. It's about dynamically integrating all 3 layers. You need the solid foundation, the skill to use it in the real world, and that ongoing lifelong drive for personal excellence that makes each person unique and valuable.
Well, as we wrap up this deep dive, maybe something for you to think about is this. How might this multi-layered view of competence change how you look at your own professional development, whatever your field is. Think about which layer maybe you focus on most right now. And how does that idea of personalized competence, that art, resonate with how you understand expertise anywhere in work or life? Definitely some food for thought there. Thanks for joining us for this exploration.